Well, I talk about the change in protein metabolism. Okay? One of the first system effects is protein metabolism. CKD causes progressive muscle wasting due to increased catabolism and the accumulation of uremic toxins. This results in loss of strength, weight loss, and an increased risk of complication. Okay, the accumulation of urea and creatinine in the blood causes anorexia, nausea, and fatigue, which reduce food intake and accelerates muscle loss. In addition, the chronic inflammation that accompanies CKD increases protein catabolism. Even when the patient consumes adequate amounts of protein, this leads to a condition known now as protein energy malnutrition, which increases vulnerability to infection and reduces the ability to recover after hospitalization. In the early stage, the specialists recommended a low protein diet of zero point 0.6 to zero point 0.8 grams per kilogram of body weight, so as not to overload the kidneys. But when the patient required dialysis, the story changed. Okay, between 1 and 1.3 grams per kilogram are needed, as the treatment removes some of the body's proteins and amino acids. Alterations in carbohydrate metabolism. Okay, the carbohydrate management is also compromised. Decreased kidney function reduces insulin elimination and the ability to produce glucose. This causes a dangerous roller coaster of blood sugar, alternating between hyperglycemia and hypoglycemia. Okay, for this reason, CKD is often associated with insulin resistance and an increased risk of developing diabetes, or worsening control in patients already diagnosed. In fact, diabetes mellitus is the leading cause of CKD worldwide, closing a vicious circle. Diabetes damages the kidneys, and the said kidneys destabilize blood glucose. Her strategies include continuous glucose, monitored and adapted meal plans. In patients on peritoneal dialysis, carbohydrate consumption should even be reduced due to glucose absorption from the dialysate fluid. In the alterations in lipid metabolism, in the case of fats, CKD is associated with a highly atherogenic lipid profile, elevate triglycerides, decrease HDL cholesterol, and increased small, dense LDL particles. All of this increase the risk of heart attacks and accelerates kidney damage. This dyslipidemic profile means that patients with CKD have a cardiovascular risk 20 times higher than the general population. In fact, most deaths in patients with CKD are not directly due to kidney failure, but to cardiovascular complications such as myocardial infarction and stroke. A diet low in saturated fats, increased fiber intake, and adapted physical activity are key tools alongside drug therapy. Treatment combines drugs such as statins and fibrates, while lifestyle change, balanced diets, weight control, and adapted physical activity. Well, well, for closing, chronic kidney disease is not just a filtration problem. It is a systemic condition that affects multiple areas of metabolism and nutrition. Okay? Detecting it early and applying comprehensive prevention and treatment strategies can make the difference between a limited life and a full life. Prevention includes simple but powerful measures, maintaining a balanced diet, controlling blood pressure and glucose levels, avoiding excessive consumption of salt and nephrotoxic painkillers, and regular medical checkups for people with risk factors. The key is to educate the population and promote healthy lifestyles because every kidney care for today means years of active and healthy life in the future. Thank you.